the session continues. So pnawn da bawb, afternoon everybody, croeso I sesiwn Ginio Dysgu a gynhale gan raglen gwasanaethau ymsodiadau Rywol Cymru. Welcome everyone to the Welsh Sexual Assault Services Lunch and Learn session. I'm Jo Williams, I'm the Programme Director for Welsh Sexual Assault Services. And I'm really pleased that today's session is going to be looking at sexual assault for veterans. And Peter Kellen and Neil Kitchener are going to be taking us through the session today. So welcome to both of you. And I will hand you over to Peter. Thank you all.
Diolch, Jo, prynawn da I bawb. Thanks, Jo. Good afternoon to all. I'll continue in English if that's okay. My name is Peter Kellen. I am head of the Armed Forces branch within Welsh Government. I know Neil is there. I don't know if Neil wants to sort of come on and briefly sort of introduce himself, but.
Oh, thank you, Peter. Thank you, everyone. So I'm Neil Kitchener, Director and Consultant Clinical Lead based at Cardiff and Vale Health Board for Veterans NHS Wales. And
this is a bit of a two-parter in terms of the slideshow that we'll take you through, and then opening up for questions. I'll start off, and then Neil will cover his area after me. But thanks very much for your time today. I hope this is going to be an interesting session. What I want to do is, and to go to slide 2, sorry, is really give you a brief introduction and raise awareness of a piece of work which you may have heard of or you may not. It's gone under a couple of different names. The official title is the LGBT Veterans Independent Review, but in honour or in kudos to Lord Everton, KC, who was the author of the review, it's sort of got an informal name as the Everton Review. I've never been able to say my THs correctly, as my mum always used to point out, so it's Etherton, as in ETH, rather than Everton, the football club. And from that review, I think if there's an outcome from today, it's really trying to maybe identify some of the connections maybe between sexual assault services and veterans support. Just very briefly to set the scene in general before we talk about the review itself, the maybe varying levels of familiarity within the this group by what we actually mean as a veteran. The UK definition is quite a sort of broad and all-embracing one. It's anybody who has done more than a day's service in His Majesty's, as was, armed forces, Army, Navy, and the Air Force, but 1 day's service, and it covers both those who've served in regular service, but also territorial and reserve units as well. So in theory, somebody could have done a day's training and then would still be a veteran. And the very term veteran itself is a term that some people like and use and are quite proud of, and for some it's quite emotive and they don't particularly want to identify as a veteran or even formally having served. So it's not a sort of given that everybody identifies themselves who served in the army as veteran. Within Wales, the 2021 census tells us that we have 115,000 people who have previously served in the armed forces. Generally, those people match the rest of the population pretty closely in terms of let's call them sort of life outcomes, that in terms of health, jobs, offending, employment, there isn't a great deal of sort of divergence, but there is vulnerability within the community of veterans or people who have previously served within the armed forces. Maybe many different reasons for that vulnerability. People may enter with significant history behind them, such as adverse childhood experiences. The military environment itself, there is both an operational military environment, but not everybody who serves in the military will have what people may say seen combat or been placed in a operational context, or what the army would sometimes refer to at the moment as kinetic, i.e. with things flying around. But the training environment is quite unique. The hierarchies are quite unique, and even the legal system is quite unique. That military law, for example, gives people very wide-ranging powers in terms of discipline, and some quite different offences or things that would possibly pass in normal life within the context of a unit can be dealt with through a disciplinary procedure, which can still involve sort of the ability to lock somebody up. And my own sort of lived experience in this, which I should maybe have introduced from the start, that whilst I am now a civil servant, but when Centurion was a rank rather than a tank, which is an old military reference, I served in the Royal Regiment of Wales from 1987 to 1995. So in the context of this review and this report, it's an environment I'm familiar with, but I also know it's an environment that has moved on somewhat, but hierarchies, power, and still remain, and you will still be seeing articles in the paper that show that whilst great improvements have been made, it can still be the potential for coercion, abuse and trauma continues. And lastly on my slide, so we talked about vulnerability, is the Armed Forces Covenant. Now this covenant is a covenant between state and the individual that in essence says that as a result of your service, you should not be subsequently disadvantaged in civilian life. And in certain circumstances, such as death or bereavement, because the covenant covers not just those who serve, but their families as well, that consideration may be given in terms of prioritising services. It relates primarily to housing, health and education. And just in case of feedback, I'm going to move to headphones in case I might be the source of it on my computer. So bear with me 20 seconds.
Has that reduced the feedback at all? Okay, apologies for that. Brilliant. I won't start again. I'll move on to the report. But as I said, the aim of this is to introduce you to the Everton report, to the LGBT independent review. The slide, you've got a copy and there's a web link, and please do take a look at it afterwards. But quite incredibly, looking back prior to the year 2000, one of the peculiarities of service in the armed forces was that there was, and I'm always struggling in a way to find the right term, but the phrase gay ban is being used, but homosexuality was specifically prescribed within military law, and it was only in the year 2000 that that was changed. That meant an awful lot of suffering for people prior to that time who either tried to keep their sexuality hidden or were found out, whose service careers were sort of ruined by that fact. And what was acceptable at the time, pressure after that time was put on, and a sort of a known wrong is partially, this is an attempt to partially right and provide redress to a known wrong through a full UK government inquiry into the environment and collection of testimony from those who suffered within that environment, and then some forms of redress to try and put that right. And we expect fairly shortly a full response from the UK government, but they issued a partial response in July, which included a formal public apology from the Prime Minister. So just referring to the pre-2000 environment, there was a ban in place across the forces. I've alluded to the culture previously, that it was a culture where there was a very rigid, and to an extent still remains, a hierarchy with power relationships. Alcohol was rife and in sort of culturally endemic. I probably still have the hangover from service 87 to 95, presented with a jam jar full of ibuprofen on day one within the regiment, saying you will need this. The British Army of the Rhine and most other places, you're expected to drink most days, and expected to drink to excess within a closed unit environment that that liked to keep things in-house as well. So tended to be what went on in camp. Commanding officers and chain of command would try and do everything to keep what went on in camp. So there's a rife environment for bullying, coercion, abuse, and assault. And within that slide at the bottom, there's just one of the pieces of testimony explaining one of the situations. And the report, whilst the focus is on the LGBT community who were serving in the army at the time, that abuse, that coercion, that sexual assault wasn't isolated to that community, but it was that is what the report concentrates on. So just again, a brief slide just explaining how military law approached the matter. The evidence and testimony that was provided to review, it is a harrowing, distressing, and disturbing read to go through. And for somebody, I mean, personally, for somebody who served at the time and looking back, you realise quite what a toxic environment you live within, and how ignorant you were to it at the time. But that's from the privilege of somebody who served and was never affected. How it must have been for those who were directly affected, I can only, I can't even come close to imagining. But voluntary termination, people were moved to the side, careers were stalled and stymied. People could be subject to medical investigation, abusive investigations as well. The Army has its own special investigations branch, which would, on suspicion of your sexual orientation, subject you to interviews in a cell of quite horrific nature. Financial difficulty. There's a lack of pastoral care within units. Some of the after effects, as what started within the forces, if a career was ruined, then has manifested itself in homelessness afterwards, and poor mental health, and self-esteem. So some of the impacts. The report makes the point, quite correctly, that female veterans suffered particularly severely from sexual assault, bullying and harassment within this environment. It also makes the point that they identify less as veterans than their male counterparts. And for that reason, not all will turn to veterans charitable organisations for their needs, because there is still, to quite an extent, using my own phrases, something like a pale male hegemony, if that is sort of safe to say, within many organisations. That has been the culture for a long time, and like a battleship, takes time to change and turn around. The report identified that many third sector organisations and support services are not as inclusive as they could be, and reflect the same behaviours and structures that might therefore disadvantage female veterans, and for that reason female veterans may be less likely to approach such organisations for assistance and support. So the review is interested in how female veterans can be supported who, as traumas maybe are refreshed from the publication of the report, are supported. It also recognises that there is a challenge in terms of delays in coming forward. So whilst the report sort of identifies a situation now, there is a legacy going forward to acknowledge and to recognise. There is some support out there that is inclusive and special, provides a special source of support for the LGBTQ community. Fighting with Pride are the lead third sector organisation, and they have a wonderful presence in Wales through Ruth Birch, their support officer, who some of you may have met previously. But Fighting with Pride were really formed to advocate for the review to take place, but they are the experts really now in terms of support to LGBTQ veterans. And one of the ways in which the review identified organisations could provide or demonstrate their support and provide an inclusive environment was through adoption of the Fighting with Pride in Veterans standard. And the response in Wales has been quite astounding, really. I think we're around about 10%, I may have got that wrong, 20% of the UK signatories so far to the Pride in Veterans standard. That's included Neil and Veterans NHS Wales, who are identified here, 4 out of 7 of our health boards, but also the third sector in Wales, who work with the armed forces community. In relation to that point that Lord Everton made, have really stepped up to the plate. So that's my introduction to the review. Just noticing something coming through on chat. Okay, noted. Yeah, it was a complex environment. Neil, shall I hand on to you at this stage?
Yeah, unless there's any questions, Peter.
Yeah, shall we take questions at this point and then questions again at the end? But I'm more than happy to to take some questions now. Okay, I'll take that silence as either stunned or it's not a requirement in the DRS award, as I understand, nor can Welsh Government, for example, mandate it within Wales. But what we have been doing as far as we can through the various armed forces forums we have in Wales. So we have a local government forum, we have a Wales charities group, and we have a health champions forum. Is doing what we can to encourage, but it is visible as in relation to the DRS is the Defence Employer Recognition Scheme, and that's a gold, silver, bronze award that organisations can go for, and part of that is demonstrating how they connect with and reach out to the armed forces community, both within their organisation and within the wider community. Thanks, Bev, for that question.
Okay, I'll take over then. Thanks, Peter. I should also say that I'm a veteran of the Army. I was a reservist between 2011 and 5 years service, and deployed to Afghanistan with 203 Field Hospital, October 2013 to January 2014, as part of the Field Mental Health Team. I also like to say that Fighting with Pride helped us with our website when we revamped it, and I asked Craig and Caroline if they would look at our website as it stood, and they gave us some really helpful advice on to make it more inclusive. And so we have some, I hope, some very inclusive photos within the website, which I'd recommend that you do have a quick look at, that should show that Veterans NHS Wales is an LGBT plus friendly service. So I'm going to talk about Veterans NHS Wales, and think you probably all know that there is a service in Wales, but just for those of you that aren't familiar, we're funded by Welsh Government since 2010. We had a pilot for 2 years in 2008 to 2010, which was based in Cardiff and Vale Health Board and Cwmtaf Morgannwg, as it was then. And we showed that the pilot over 2 years had veterans who would come forward to the NHS and with a service-related mental health problem take treatment, psychological treatment, medication and support from other charities. The Welsh Government funded Veterans NHS Wales in 2010, so I'm going to just show you some slides about that. We have an annual report which is on the website, which I'll direct you to as well. So a lot of the slides I'm about to show you are taken from the April 2021, March 22 annual report. And this data is collected on every veteran who is assessed by therapists across all the 7 health boards. And then the data is sent to Cardiff in October each year for us to do some number crunching and come up with some data to produce this report. Next slide, please. That's pretty small, but basically that shows you in your health board who the key therapists are. So just as a quick orientation, every health board has a clinical lead, so that would be a band 8A psychological therapist. There'd also be band 7 psychological therapists. There'll be a consultant psychiatrist who works one day per month. I just want to stress that again, that's 1 day per month, and can see our patients, our veterans, for a second opinion and medication review. And we also, in some health boards, so BCU in North Wales and an R in Bevan, also employ peer mentors. And so these are individuals who've served in the military and now have been trained to be peer mentors, and they will go out and talk to people that are referred to us, and they could meet them in their own home or meet them elsewhere in the community, the veterans talk, sell the service to that individual and any issues or concerns they have about coming to see the therapist. And they would also work on their social issues, so around employment, debt, housing, children, etc., etc. They can help navigate the Veterans Services charities that can help with those issues. The veteran would then come and have an assessment with a veterans therapist. We have Welsh Government guidelines that say we must try and assess someone within 28 days, and then we must start treatment within 26 weeks after that assessment. And I'm pleased to say that in most health boards, we're achieving that at present. Next slide, please. So this is the website. This is one of the slides on the homepage. So it's just veteranswales.co.uk. I've put it into the chat for you to have a look at. Please do if you're not familiar with it. And basically, the website is a vehicle for veterans who reside in Wales, who have a service-related, or they think they have a service-related mental health problem, to fill out an online form that will come to us in Cardiff and Vale, and then we'll send it to whichever health board the veteran resides in, and then they'll be offered an appointment with a psychological therapist for an assessment. So lots of data and lots of useful information, and also the annual report is on that website. Next slide, please, Peter. Yeah, just say we've recently had the Royal College of Psychiatrists accreditation, which I'm very pleased about, and this is for Cardiff and Vale Veterans Hub service where I work, and we've basically been peer reviewed by other services within the health boards around the UK. In the UK, Northern Ireland, who have come to Cardiff and Vale, looked at the veteran service and what we offer, spoken to some patients, some carers, the therapists and the management, and gone away and rated us as either meeting the criteria for this accreditation, which I'm pleased to say that we did, and then we'll be peer reviewed again in 3 years' time to make sure we're still keeping to those standards that we should meet. So that's been a very helpful process, and part of that accreditation talks about LGBT plus making the environment welcoming and useful. Next slide, please. So just some data from the annual report 21-22. You can see that we started in 2010 with 191 referrals across Wales, and that's steadily increased up to 831, which was just before the pandemic hit. And like most NHS services, we stopped seeing people face to face and our numbers dropped off. We were seeing people online after a few days with whatever technology we could use, including WhatsApp and Facebook and FaceTime, I should say, Zoom, etc., etc. So the numbers have steadily started to climb again, and I'm pleased to say I expect that to continue. Although I should caveat that with, because we're not at war anymore in a major conflict as we were in Afghanistan, and there may be a drop in numbers. We'll have to see over the next few years. Referrals by health board, you can see that Swansea Bay has had the most referrals in this year, followed by Cwmtaf Morgannwg, who now cover Bridgend Porthcawl, as well as the old Cwmtaf boundary. BCU and AB closely behind that curve, and then West Wales and Cardiff and Vale have fewer referrals. Yeah. Next slide, please. Next slide, please. Deployments, most people that we see have deployed, but not everybody has. But those people that have deployed have often deployed several times in their career. And so Northern Ireland, as you know, the Troubles was a 35-year conflict. So lots of veterans have served multiple times in Northern Ireland, as have the Iraq 97 Iran conflict, Bosnia peacekeeping, Afghanistan, which was 2001 to 2014, again a long campaign, and the second Gulf. So lots of the people we see have probably gone to several of those theatres in their career, and may have had some, some difficult moments where they felt they were going to be seriously injured or killed, or witnessed other people seriously injured or killed. Next slide. We ask all our service users at the end of their treatment with us, which is up to about 16 weeks, we say, although we do extend that for people that need longer sessions. But on average, people see us for about 16-ish sessions, and you can see that the blue is strongly agree. So that's usually an indication that we're doing a fairly good job. Where it's not so good is some of the environments that we see veterans in some of the health boards aren't up to scratch, i.e. the environment's not very welcoming because it's an old NHS building or it was a bit cold. So there's room for improvement on that service user feedback, but generally very good feedback. Next slide. And we get some very nice comments, which you can't read, but they're basically saying, I really like my therapist. The therapist understood me, gave me time. They used some evidence-based psychological therapy techniques, which have helped resolve many of my symptoms to a point where I can function much better in work and at home and in relationships. Excuse me. Next slide, please. I also want to say that we work closely with the Cardiff University Traumatic Stress Research Group, and most of you have probably heard of Professor Jonathan Bisson, who's a consultant psychiatrist and was a major in the army. He did his med school funded by the army and stayed for 5 years and became interested in post-traumatic stress disorder particularly, and started the first traumatic stress service in Cardiff, and we now have Traumatic Stress Wales, as you know, across all health boards on the back of John's work. But we do some research with that group, and I'm part of that group and have been since it started, and we've done a few randomized controlled trials, and you may remember the 3MDR trial using a novel Dutch treatment for PTSD using a treadmill and a virtual reality screen based in UHW hospital to treat complex PTSD. We've also trialed and tested Spring, which is a guided self-help website, which also had veterans involved in the 3 studies that we did. And we've had money from the Office of Veterans Affairs to produce a military version of Spring, which is again a guided self-help website. So we'll be testing that soon with 10 veterans across the health boards in the next few months. Next slide, please. Current challenges. Like all NHS services who employ psychological therapists, there are a lack of psychological therapists trained in Wales and the UK for that matter. And so when new services open or opportunities for promotion rear their head, then we obviously lose staff. So retention and recruitment of staff can be a problem. Although I have to say the majority of our veterans therapists have been with us since 2010, 2011. So I think that's a testament to they like working with this occupational group and the conditions that they work in, and we have a generous CPT budget to keep them with us. I've already mentioned, if you just go back a slide. I don't know who's doing the slides. Yeah, thank you. I've already mentioned that the peer mentors in the health boards are only in BCU and AB, and I'd like to, my mission, as Peter knows and others know on the call, that my mission is to try and make that equal across all the health boards. And that's challenging because it means the NHS health boards have to find money for peer mentors on a band 3 or 4, and that's very difficult in the current environment when health boards are asked to make cost savings. But that's my mission, to try and have peer mentors in every health board until I retire. I've got 7 years, so I hope to do that before 7 years happens. I also want to acknowledge that it's quite hard work at times. So as Peter alluded to, the environment and hierarchy and the abuse that goes on in the military historically still happens, and we still see people that have been affected by those challenges that they've been exposed to. And so we have some high intensity individuals who carry a certain amount of risk, and by risk I mean risk probably to themselves mainly, and others, but mainly to self, and we've certainly lost individuals to suicide over the 13 years that we've been across Wales, but also the drain on our staff who have to carry that risk. And we, if I'm honest, we probably take on and hold on to people sometimes who, you know, would benefit from being stepped up to the community mental health teams, who are reluctant to take individuals at times because they're military background. So I just want to acknowledge how hard our therapists work and what a good job that they do with some very challenging and difficult people. The charitable landscape has changed and shrinking, as you probably know, if you work in those services, particularly because of the Afghan war has stopped, and so it's not in the news and people aren't rattling tins and giving money as much as they used to, and that's caused a lot of changes in our field, including peer mentors in charitable services that have now been cut, and we don't have that access to refer to anymore. Next slide. So I'm just going to talk about a case that I'm working with currently. I've changed this individual's name and where they're from, and changed their age, and I have their permission to use these slides. So I'll call her Lou. So Lou was referred by the Defence Community Mental Health Team in Plymouth. So Defence Community Mental Health Team is like a NHS community mental health team, which is made up of military and uniformed and non-uniformed individuals. So consultant psychiatrist, consultant clinical psychologist, psychological therapists, and social workers. And so that makes up a DCMH. And if you're serving and you have a mental health problem, your first port of call after seeing the GP in the military is to be referred to the Defence Community Mental Health Team. And then that team will assess you and treat you accordingly for your mental health problems. If they can't fix you as a serving person, they will then recommend that you're discharged on medical mental health grounds, and you'll become the NHS's patient. So in Wales, that's Veterans NHS Wales, and in England, that would be Op Courage, which is the English service for veterans with service-related mental health problems. So Lou's a 26-year-old Royal Navy veteran who was medically discharged from DCMH Plymouth. She was diagnosed with post-traumatic stress disorder after a military sexual trauma. And so she's a heterosexual lady. She was assaulted and raped by a senior male rating. So this is a 40-year-old married man who was probably 3 ranks above her, who was inappropriate, would inappropriately say things to her in the office that she shared with him, would touch her inappropriately, and on one occasion when she was drunk, raped her in her accommodation. So Lou was diagnosed with post-traumatic stress symptoms, including reliving symptoms, so nightmares of being trapped in his office or in her room, or the traumatic event that she'd had to go through, given evidence to the Special Investigation Branch that Peter mentioned, which is really stressful, and then giving evidence in court against her perpetrator. So she has intrusive images of assaults several times a week during the daytime, and she's avoiding going back to Plymouth Naval Base, the actual accommodation block where it happened, and she trying to avoid busy places where she lives now. She's hypervigilant, so that means she's always checking to see if there's any danger, i.e. males who could be lurking and a danger to her, and she dislikes males standing behind her. She avoids thinking about the assaults, and she has cognitions which I'm vulnerable. Next slide, please. So, bit of a early life. So Lou is the youngest daughter of 3 siblings. Her parents would argue and fight after her father drank excessive alcohol. She and her siblings did not feel safe at home due to the above arguing with her parents. And her older sister left home as soon as she could at 18 years old because of it. Her father never went to watch her play her various sports. She was an excellent sports woman, but he never went. And her mother, she describes as tactile and a nice person, but has some chronic health problems and ends up with Lou actually caring for her mum a lot of the time. The family don't share thoughts and feelings, so that's very difficult when you're upset as a child, if you can't share your thoughts and feelings to your mum and dad. But also when Lou came back from the Royal Navy after being medically discharged, she's never told them why she was discharged and what happened. Next slide, please. So she lived in Cardiff, attended local schools, which she didn't really enjoy. She was quiet at school, had a few friends. She obtained GCSEs at BC grades. And what I found quite interesting and a bit shocking, really, was she joined the Royal Navy at 16 years and 9 months. So this is a very, very young lady who just left school. And at 16 years, 9 months, she joined the Royal Navy. She served 5.5 years before being medically discharged by DCMH with PTSD, and she went home to live with her parents. She's applied for Armed Forces compensation for PTSD, and that's going through the process at the moment. I'm confident that she will be awarded a psychological injury of post-traumatic stress disorder because of the assaults that were inflicted upon her. The good news is she's currently training to become a paramedic, and so she's at university, and she seems to be enjoying that new career potential there. Next slide, please. We always ask our patients, so at the end of your 16 sessions of treatment, what would you like to be able to do that you can't do now? She said, I'd like to sleep for 7 to 8 hours each night with minimal disruption, so without having these horrible nightmares and waking up panicky, to feel less panicky and hypervigilant when I'm out of the house alone and stop checking my surroundings for danger, to feel comfortable when socializing with friends, and to be able to make new friends with minimal anxiety. So that's what we're aiming for towards the end of her treatment. Next slide, please. And so Lou would have had an assessment. In fact, I assessed her with our assistant psychologist 12 months ago. Actually, it was December last year, and she was referred to our psychiatrist for a medication opinion and has been prescribed a sedative antidepressant. Her mood was a bit low, and actually this antidepressant, if you take it at night time, also helps you get off to sleep a bit better. We liaised with the Defence Community Mental Health Team Plymouth, who had been treating her, and got their notes, and I had a chat with the psychological therapist there, and we've asked the GP for a previous medication and psychological treatments, just to build up a bigger picture of her and formulate her problems. And she's currently engaged in weekly outpatient trauma-focused psychological therapy for post-traumatic stress disorder, and we're doing that by walk and talk, EMDR. So EMDR stands for eye movement desensitization and reprocessing therapy, which is an evidence-based treatment, NICE endorsed treatment for PTSD, American in origin, and works very well. And since the pandemic, therapists have been trying to become inventive, really, and have tested it using outdoor green space in a nice country park or forest, or in West Wales, it's down on the coastal path or in a nice park there, where we get the patient to relive their traumatic memory whilst focusing on their feet as they hit the floor, and that bilateral stimulation helps process the traumatic memory to where it should be in the past, remembering that everybody's trauma is in the past and not happening now. So that seems to be working quite well. She's about halfway through her treatment at the moment, and we're having some good successes with that. And next slide, if there is one. I'm not sure if there is. No, that could be it for me. So I've just given you a case example of a military sexual trauma, and I've just given you some slides about veterans in NHS Wales and where to find our website should you want to look at that. Peter and I are happy to take any questions that you may have for us. Thank you.
Thank you both. Are there any questions for Peter or Neil? Catrin?
Hi, thanks both. I'm the clinical lead in NSAF SAC in Cardiff. I suppose I was just thinking about, are there any things that or any sort of thing that you can think of that we need to do to reduce any barriers to people coming forward to using SAC services? Are there particular sort of things that maybe put veterans off from accessing our services that we need to think about?
Yeah. Do you know how many people are veterans who have access to your service?
I don't, and I don't know whether we're measuring it either necessarily.
So that would be an interesting first step to make it mandatory to ask your patients, have they served? The GPs do this in primary care, and it's a very helpful piece of data for the health board and yourself. He just got his hand up. I think he may have a response.
Just building on that, yes, the GP accreditation scheme launched in May, so it's early days. So getting all GPs to onto the scheme will take some time, but in essence, it's an opportunity that the scheme educates GP settings about the veteran community, encourages registration. The more data we can get, the better, really. I think in relation to the review, I'm sort of interested in a way understanding how, and I don't think it's just women who've been affected by the review, but sort of women in general can feel confident, and how when Lord Everton refers to a sort of a female-only pathway, is that something that almost exists anyway, because you are already being quite receptive, or particularly receptive to what I would, and being slightly this isn't my normal line of work, would think that most people presenting to you would be female.
I'll just speak what
please.
About, I should have said earlier, actually, only 5 to 7% of the referrals I've shown you each year are from female veterans. So that's very interesting, I think. So why don't female veterans want to come to Veterans NHS Wales? And it could be that they view it as a male service for frontline soldiers who are usually men, but aren't anymore, because women are allowed to go onto the front line and fight and kill people. But in the past, it's just been the male domain. And so there may be a historical stigma there that females should go elsewhere, whether that's to SARC or GP or other services, I don't know. And it sounds like we probably need to collect that data more routinely than we do.
Yeah, thanks both. And as Andy popped into the sidebar, then we are looking to collect data on veterans going forward as part of our performance monitoring. So hopefully we'll be able to provide data probably from 2024-25 going forward to see how many veterans are accessing our SARC services.
I think that would be really helpful, because I again, with the dangers of generalizing, but sometimes there is maybe a reluctance within the community to seek support, and then as we said, within elements of the community who may not even identify themselves as veterans either. So yeah, anything that can be done in a way to count and identify it, and enables us in a way to take a look sometime down the road and understand a little bit more. I mean, what we do know is that, both from the report and generally, is that the military has produced a fairly unique environment, which probably ought to be reflected to some extent in that sort of presentations. But to what extent, I don't know.
Yeah, no, I agree. And I'm just thinking about what you said about women like who don't identify as veterans. Maybe it would be worth asking the question, have you ever served, rather than are you a veteran, if women don't tend to identify as a veteran to capture the data.
Yes. Yeah, it's a much better ask. Have you previously served in the armed forces? A really sort of all embracing question. Yeah, the whole veteran thing is quite emotionally loaded, especially for somebody whose service wasn't perfect. If you know what I mean, in terms of you know, left, or you know, the relationship with the army is a damaged one, and for all sorts of reasons it can be.
Thank you. Are there any further questions? No. No hands. Okay.
Thank you, sir.
No, thank you both for today. That was really interesting, and as I think taught us a lot on what we need to do to help support veterans going forward, and giving us a lot of information to think about the provision of our services. So so thank you both. The recording will be available on our website for anybody who wants to access it, and I know that there have been a couple of links posted as well in the sidebar that people will be able to access. So just once again, thank you, diolch, and we'll see you all for the next Lunch and Learn session that is going to be in a couple of weeks. So thank you again all, and see you soon.
Bye.
Thank you.